Our next speaker is Dr. Nayanjeet Choudary, who serves as the director of the Amrita Patel Center for Public Health in Gujarat and as a consultant with the Regional Health and Family Welfare Training Center, Government of Meghalaya. Managing chronic illness requires a sustained community-centric approach that integrates medical care with social and behavioral support systems. In today's talk, Dr. Choudary will shed light on the challenges and opportunities in delivering long-term care and how a continuum-based approach can transform patient outcomes and community health. Dr. Nayanjeet Choudary.
Thanks. My humble salutations to Bhagwan Sri Sathya Sai Baba for arranging this invitation through the voice of Dr. Sundaresh, because this is the first time I'm visiting. And I was stunned to have received the invitation because when I studied about the Sri Sathya Sai ideal healthcare model, I realized that all the public health training I had over the last more than 2 decades could have been actually studied by being a part of this model itself. So I was slightly frightened as to how do I speak in front of such august audience with stalwarts that we have seen sharing their wisdom since morning. Would I be tongue-tied? And then my good friend, Dr. Raja, who's come from Hyderabad, he said, don't worry. You have come here because of the divine manifestation of a reason that you should be here. And therefore, whatever you would speak, probably Baba has already organized for you to speak. So with that in mind, I initially prepared a very interesting, very scholarly presentation, according to my own faith, about how the Sri Sathya Sai ideal healthcare model can be adopted by the universal healthcare approach of low and middle income countries, and particularly India. And I created a very flashy deck of slides and sent it to Dr. Sundaresh. And it seems a couple of days later, I received a message through one of his colleagues saying that, would you like to tweak the slides? Because everybody else will be talking about our model. Why don't you talk about something that's not part of the model that you bring in from your experience? Now I am thinking that it's probably Baba who has designed it this way so that I can tell you from a third eye lens, a perspective that exactly resonates the Sri Sathya Sai healthcare model, but the global audience and literature scientifically actually endorses it. But let's see how much I can achieve that. So needless to mention, Dr. Mohan Sir has already told us how escalating prevalence of diabetes, but also cardiovascular diseases, cancer, and all other chronic diseases have been rising. But there is a significant spurt after COVID, including a lot of neurological problems. Now, the biggest burden is on the poor. There's a disproportionate impact for the poor to bear the brunt. Thanks to my PhD student, Dr. Deepika, who has made most of the photographs using AI. So no informed consent was necessary, except one photograph that I'll be sharing. That's from one of my projects. So in a very commonsensical approach. This is chronic care. You have a population at risk. You have an individual at risk. The individual decides at one point in time to seek care and therefore approaches a practitioner either in the public sector or the private sector or formal or informal caregiver. And then an initial diagnosis happens. If necessary, a higher level of care is sought, and then a final diagnosis or a definitive diagnosis is reached, and then probably there is a higher order of treatment depending on the condition of the person or the complications the person is undergoing. And eventually there is complication management and rehabilitation and so on and so forth. So that's the kind of cascade of chronic care, be it cardiovascular disease or a lung disease or diabetes or metabolic diseases or cancer or you name it. Of course, nowadays the difference between communicable and non-communicable disease has really gone. It's sort of probably two sides of the same coin. So there are different levels of prevention and levels of care sort of are named in terms of prevention, primary care, specialist care, and then rehabilitative and palliative care. All this is amalgamated in the Sri Sathya Sai ideal healthcare in the form of universal, comprehensive, holistic, loving, and free care. Free care. So when you say free care in the universal health coverage, we call it subsidized care. So the subsidized, when it is 100% subsidized, is free care, and that's possible. This is what is already established in this model. So way back in 1998, Dr. E.H. Wagner, a practitioner in US, had talked about this chronic care model, CCM. This is a very interesting model, and I'm sure you will feel resonance is this. So you have a community and you have a health system. In the health system, you have decisional supports in the form of caregivers and equipment and machinery and others. And you have a delivery care protocol or systems. You also have support for self-care management of the patient once the patient is discharged and goes home. And there is a clinical information system. So this exists. But most important thing is, in an effective chronic care model, there's an informed, activated patient and prepared practice clinical teams who work together. It's not like a hierarchical model where there is productive interaction between the patient, the caregiver, and the practicing team. And this seamless transition eventually leads to personalized care with cost effectiveness. That's exactly what the Sri Sathya Sai ideal healthcare model probably promotes. And then we see improved outcomes. So this is not new. So at least from a theoretical perspective and a scientific perspective, this has been established across the world. This is a global model now accepted as a chronic care model. The World Bank and many other organizations have endorsed multidisciplinary approach to chronic care. Now, this is a framework of an integrated care model where you have community workers, you have home-based care, and you have hospital facilities at different levels, and then you have referral cares of different kinds. Now, there are different permutations and combinations of this integrated care that are being promoted. One of them, which is very well demonstrated in this model here, is what is called task shifting. You don't name it, but the world already has named task shifting. I think WHO talked about task shifting way back in early 90s when cervical cancer screening, the WHO proposed that pap smear should be replaced with VIA and VLE, which is something that high school students could be even or high school pass students can be trained to do at a very, very low cost, and then the care cascade can happen. So this is task shifting. So if task shifting happens, what happens is a specialist doctor can be absolved of a lot of responsibilities, okay? And then a general practitioner can also become a guide to community volunteers, despite, of course, besides doing the protocol-based treatment. And then a nurse can do active screening of patients for chronic diseases using protocol-based systems, and even start treatment initiation. Um, a community health worker or a volunteer can do counseling work. And then a very important component of a task-shifted model is a very integrated digital space where you collect data real time and inform decisions real time so that complications can be prevented. So I think this already exists in Sri Sathya Sai ideal healthcare model. So this is nothing. It's all sort of a visible in front of our eyes since morning, and that's exactly what I'm trying to endorse with scientific literature. All right, so beyond that, community engagement has been proposed as an evidence-based, proven model for chronic care that's going on here. Peer support groups is a very significant model. Digital tools and telemedicine, you have already presented enormous information on that. Integrated disease care models, so multiple diseases clubbed into one screening program that has been tested since the HIV days. And very importantly, evidence-based, culturally adapted interventions. So an intervention in urban Shimla will not be the same in rural Udaipur. So how do we contextually adapt them? And then most importantly, like a couple of previous speakers also said, a very strong partnership and leadership across the board. It's not like private care or public care. Everybody, and Mohan sir also said, everybody has to be part of the game. So sorry about the alignment over there. So this is an example of an experiment I was part of. This was HealthRise, a global program in 4 countries, and I was overlooking all the program. And the last leg of the India program, we introduced a community empowerment model called SALT CLCP. In that, so SALT stands for stimulation, appreciation, learning and transfer, and the community life competence process. It is promoted by an organization called Constellation, based out of Belgium. They have done it in almost 70 countries worldwide. So they wanted to check if serious transfer of ownership to the community for owning its own healthcare can really make an impact on their clinical outcomes. So this had 4 arms, 3 intervention arms of different kinds, and 1 pure control arm where they had only government services. And it was interesting to see that the intervention groups expectedly had great control, compared to the control groups. However, we were not present during the lockdown period when COVID hit us. And it was surprising for us to see that the intervention groups maintained significant control of their metabolic status, particularly diabetes and hypertension, even during COVID, when none of our volunteers were present, which means once you transfer the ownership to the community owns it. And in fact, in Udaipur, the control rates had actually gone up in the intervention groups because they probably realized that it is time for them to own their own healthcare. So this is a paper published in Indian Journal of Public Health. And like Baba promotes, the key predictors of these control were found to be, after significant logistic regression, regular physical activity, diet, and continuity of care. That's exactly where preventive care model that the Sathya Sai ideal healthcare model is promoting. One more example I'm showing here. This is a peer group exercise that is going on in one of the villages in Karnataka, where the ownership lies with the peers to manage their conditions and the conditions of their peers and the families. And if you see here, sorry, Yeah. So it was after 1 year of follow-up, both the percentage of patients controlling their blood pressure and their blood sugar was significantly higher. There's no other additional intervention except for exposure to government health facilities. The only peer support group. So this is where I'm trying to invest a little time asking our esteemed leaders here to probably look at data in terms of community empowerment exercises that are going on across the country through the Sathya Sai organizations, and to see how this spiritual inclusion in their pursuit of divinity as well as humanity is creating any change in their clinical outcomes, if at all. So so I think I could have avoided all my slides. These are the only last two slides that I should have been speaking about. So this is called a wicked problem. A chronic care disease is a wicked problem. Way back in 1973, Rittel and Weber coined it. It's very, very complicated. I'm a diabetic person myself, and I have to take care of my medicines. I have to take care of my food. I have to take care of my sleep, my exercise. I have to do regular checkup. I have to also take care of my mental health. So it's a very complicated program. When I go to the doctor, if the doctor is too good, then he's very busy and he's not able to give me enough time. So there are interconnected causes. There are conflicting stakeholders with competing priorities. And the moment interventions change, there are a lot of challenges. For example, the moment you bring in digital healthcare, doctors are reluctant in most hospitals to accept it. This is an example I'm giving. So there is hardly communication between doctors and patients in other healthcare models. In fact, um, in Meghalaya, we are doing an experiment for the last 3 years where we are teaching every public sector doctor and every public sector nurse at all levels, all hospitals, from primary care to tertiary care, a couple of competencies they have never been exposed in their life to, from communications, from persuasion to emotional intelligence and social intelligence, to empathy, to project management, because these are the major problems they face while serving the humanity there. The clinical training is not a barrier. So this is a wicked problem. And when I learn from Sathya Sai ideal healthcare model, all I see are three things that the world should learn from. One is empower the front. When I say frontline, I'm talking about all healthcare providers, doctors, nurses, and also volunteers. And shift the ownership to the community to take care of their own health, and you do only facilitation. At the same time, build significant capacity of the providers to be able to do so, because here it is called uh, a gap which exists between, for example, an engineer and a car owner. When you drive your car to the garage, you do not know what the problem of the car is. So the engineer tells you, gives you a list and says, this is the cost, and you pay. So this is an information gap. So we need to invest in building capacity of the workforce to bridge the information gap. Radical transformation. We learn from Sri Sathya Sai ideal healthcare model and do radical transformation of the healthcare design and delivery model. And then culturally adaptive leadership. And that's exactly what I'm hearing since morning from every speaker that has had the opportunity to share their learnings. Okay, so this is the last one I want to share. So all I'm taking home from being a part of this wonderful conference is that trust building, co-learning, shared decision making, and at the most accountability to what you are committed to is the crux of an ideal healthcare model. We need to do two things. One is build communities' capacity for local health planning. But more importantly, we need to invest in redesigning the medical education curriculum. So patients are no more passive recipients of a prescription or a surgical procedure. They are significant partners to the healthcare delivery system. And a participatory approach is what we need to teach every medical student and graduate. We must teach leadership and systems thinking. I'm really impressed and floored by the organizational capacity of this organization. This is exactly where lies a system and an individual. And how do we have a forest view and a tree view and a balance between the same is what we need to teach our medical fraternity. And then context specific clinical training is all I want to take home as my learning at the feet of lotus feet of Bhagwan Baba. At the end, I want to pray. Sarve bhavantu sukhina, sarve santu niramaya, sarve bhadrani pashyantu, ma kaschit dukha bhap paget. Jai Sai Ram.
Thank you, Dr. Choudary, for giving us insights into policy and service implementation models, culturally relevant interventions, and showing us examples of coordinated care among communities.